So today we have probably one of the more important lectures. I know we had that atrocious radiation safety thing we had to listen to for the first year that started, but Chris Johnson, for those of you who don't know from the VA, probably knows more about radiation safety and the cath lab than anyone else I know. And he's going to go through and give us a talk about radiation. And those going into procedural specialties, it's really important to kind of understand the aspects of this, even in training in the cath lab. So it's better to hear it multiple times and hopefully half of it sticks at some point in time. With that, Chris, thanks for coming.
All right, so it's that time of year again. I guess I'm the January, December guy now.
Is that where you were last year?
That's where last 3 years. So it's that time of the year to get you guys nice and bored with radiation protection. So just the name radiation protection kind of insinuates that there's something to protect against. So what are the objectives of radiation protection? Okay, the first objective is to prevent the clinical occurrence or significant deterministic effects by adhering to dose limits below threshold levels. We'll go over what this is. And then to limit the risks of stochastic effects to a reasonable level in relation to other consistent with social needs, values, benefits, and economic factors. So what does all that mean? So what are the effects if you're exposed to radiation? And I'm talking about ionizing radiation, and in our case, fluoroscopy and X-ray, okay? Same things would go also with CT, and I think those are the only two X-ray studies you guys really. So there's somatic effects, or what happens to whatever is actually being irradiated, and genetic effects are the effects that happen to, of course, offspring of whoever was irradiated. And the somatic effects can be broken down into two categories: early effects and late effects. Early effects tend to be deterministic. The severity of the effect is affected by how much radiation you get. Where late effects tend to be stochastic, which is your chance of getting the effect increases with your dose. The severity of the effect doesn't change, okay? Two late effects that pertain to interventional fluoroscopy or even diagnostic fluoroscopy, if you do a lot of them, are two deterministic effects of cataracts and chronic occupational radiodermatitis. So this is hair loss and dry, scaly skin over a lifetime of being exposed to radiation, okay? Now, early deterministic effects, if you ever get early skin damage and loss of hair from being a fluoroscopic operator, you're really messing up, okay? So, and I'm gonna talk about genetic effects really quick. So pre-conception irradiation of either parent's gonads has not been shown to increase the chance of cancer or malformations in the offspring, okay? This is the International Commission on Radiation Protection. This was in 2000. They reaffirmed this statement. And this is an interesting thing, because the most often thing I hear when I yell at people for not coming into the cath lab without lead on is, I'm not having kids anymore. That is the first thing. Anesthesiologists love to say that. I'm not having kids anymore. That's not even a consideration. You know, if you're pregnant, then it's a consideration. If you are pregnant and in the cath lab, really the only way you get enough radiation to be concerned is if you're actually the patient, okay? So in the first 14 days of pregnancy, there's some chances. Once again, the amount of radiation that you need, I forgot I can use this pointer. The amount of radiation you need to get even a little bit of an increase is a lot. So basically, abdominal CTs is the only chance of increasing this. Congenital abnormalities in the second to 10 weeks, okay, once again, 1% increase per rad, that's a little bit. And then second and third trimester, once again, greater than 50 rads of radiation. So the risks are there, but they're very small. Now, do you want to do one just for the heck of it? No. But if you're actually in the cath lab working and you become pregnant, just, you know, taking a step back, wearing lead, you know, any of the chances are very low. And this is the probability of bearing healthy children as a function of radiation dose. If you notice, up to about 1 millirem, I'm going to go over units here next, 1 millirem of radiation, that's the first place where you start seeing any change in any of the statistics. So if you are an occupational exposed worker, they take this point, cut it in half, give you a safety margin, and that's how much you're allowed during your gestation period, okay? So, and this is how much you're allowed in front of your lead. So then you have your lead covering you, and so the probability is working in ionizing radiation is pretty low, as long as you become aware of it. And just approximate fetal doses from different things, okay? You can see CT doses of the abdomen and pelvis are really the only ones that you're going to get any kind of fetal dose that's going to cause any problems, okay? So in an emergency, you know, most people won't be afraid to do a CT on someone, because the probability, statistically they're there, but the probability is very low. This was a question I was thinking about last night. Has anyone ever had to do a cath on a pregnant woman having a heart attack? I don't know. For some reason I was thinking about that, and I had never heard or one acute, yeah, 3-4 years ago. So once again, what would be the risks of that? Okay. Once again, the effective doses that we give in a PCI type environment is similar to that you'd get from a chest CT. Okay. So the actual fetal dose is actually still very small. Okay. You know, get access, get down, just do, you know, hopefully you can get it without fluoroscopic guidance and just stay on the chest. The radiation dose to the fetus should be very small. Okay. So yeah, I'd never even heard of that scenario, and I was thinking about that. So there you go. So it can happen to you. Okay. So yeah, contrast. I don't even know about contrast, and that I don't know about. Anyone willing to try it? Anyone wants to do the study? Okay. So I've thrown out a couple units. So the first thing you need to be aware of are what are the units that we use within the fluoroscopy lab. I'm not going to go into any of the CT units. I've tried that in the past, and that's just, it gets goofy. Okay. So the first thing you need to know is what is the intensity coming out of the X-ray machine. Okay. We call that the for exposure, that's the air Kermal rate. Okay. That's displayed on the machine, and it's given in the units of gray. Okay, and what a gray is how much energy is deposited per kilogram of tissue. So it's joules of energy in a kilogram of tissue. That's what the definition of a gray is. And then from that, we can also get how much radiation does whoever get irradiated, how much energy do they absorb, is also in gray, joules per kilogram. I should say air Kerma is how much radiation is absorbed in air, and then absorbed dose is how much energy the patient has absorbed, okay? Patients don't like us sticking probes in them, so it's easier for us to measure how much radiation is in the air right next to them, and then through studies with phantoms, guess what their absorbed dose was, okay? Now, there are some mechanisms. You can put some film, and we can put some detectors now on patients that show kind of real-time doses, but for the most part, if you know how much radiation the machine's putting out, you can mathematically guess how much absorbed dose they're going to have, okay? Now, once you know the absorbed dose, then you have to figure out what is my potential of biological damage, or what's the biological effect of that radiation. And we have we have equivalent dose and effective dose. Equivalent dose takes in what type of radiation it was. That's the radiation weighting factor, okay? Radiation weighting factor is different types of radiation, particulate or electromagnetic, will do different amounts of biological damage per unit absorbed dose, okay? So there's a radiation weighting factor. Now, effective dose is all the studies on what's your chance of getting a cancer comes from the biggest pool of data, biggest cohort is A-bomb survivors. And you have to look at how were they exposed. Big nuclear bomb, whole bunch of radiation, full body, all at once, okay? we don't expose people that way, but that's our biggest cohort. So what if we just expose the chest? What if we just irradiate the leg? What if we just irradiate the brain? That's where they get the tissue weighting factor. So the two things to figure out effective dose is what type of radiation and what parts of the body got irradiated, okay? And they have different radiation weighting factors for that and tissue weighting factors, okay? So I like it more in a graph here. So you find out what the absorbed dose is, figure out what type of radiation it was, and that's going to give your equivalent dose, okay? Because X-rays and gamma rays compared to alpha particles, beta particles, and neutrons are a little bit different, okay? Then you say, what part of the body did I irradiate? And then you can do multiples by that. And here are your tissue weighting factors and weighting factors for different types of radiation. So X-rays, the radiation weighting factor is 1. So that's a pretty easy one to figure out because all the radiation weighting factors are based off, they compare a dose of X-ray to the other types and see how much more damage the other types do. Now, the different tissue weighting factors, you can see they've changed over time, okay? And one of interest to cardiology right now is that they've actually added the brain and it has its own right now. We'll talk about that hopefully at the end of it when I talk about what's, if you actually become interventional cardiologist, what are your chances of getting brain cancer because you're an interventional cardiologist? It's kind of a hot topic in the last 5 years, okay? So they actually, before the brain was just considered in amongst the other things, okay? So brain has its own, but you can see the different tissue weighting factors, you know, breast, colon, red bone marrow, and stomach are the most radial sensitive, okay?
You wearing shin guards in the lab?
Shin guards, that's my last slide. Yep. Yep. Yep, red marrow. And shin guards, we can discuss that at the end. Yep. And I got a fun story with that one. So graphically, when you walk in the fluoroscopy lab, where are these units used? So air kerma is going to be what's coming out of the X-ray tube, okay? And this is displayed on the X-ray machine. It'll tell you how much you've given and your exposure rate, how fast you're giving it, what's your intensity of radiation. Absorbed dose is going to be how much radiation the patient has absorbed, how much energy you've given to them. And then to get the effective and equivalent dose, you have to think of what type of radiation weighting factor, X-rays, 1, so it's not a big deal. And then your effective dose is going to be, all you should really do is irradiate the chest, okay? So in a couple slides, I'll show you how to figure out the effective dose from a cath, okay? Now, for occupationally exposed people, it gets a little more convoluted. They have another one called total effective dose equivalent, okay? And that's because occupational people can be exposed different ways. One is from external sources, and if you happen to work in some other places, there's a chance of internal sources, either inhaled, ingested, or absorbed. Okay, that's why they give it kind of its own unit. And so total effective dose equivalent is a combination of committed dose, ingested or inhaled, plus external sources. And if you look at your, I'm going to just go to this. How many of you have seen a radiation report from a badge? How many people have a badge? Okay. How many people wear their badge? Yay. Okay. So at the VA, yeah, you should bring your badge to the VA if you're going to be in the cath lab. No, we don't monitor it. Yeah, no, yeah, you should have your badge, bring it to the VA and wear it because the VA is not responsible to follow your radiation. We just had Balaji borrow one of our visitors' badges for 5 months and run around, and he actually got a pretty good amount of radiation. He got a little more than I was hoping he would. So, yeah, I was a little surprised by that. He had it for 5 months, and he got some radiation. I've monitored fellows before with the visitors' badges, and this was the highest I've seen in 4 or 5 months, which kind of worries me, you know, especially if you just had a kid. Just kidding. But anyways, so on that the types of doses that it's going to measure is your deep dose. This is the dose which is going to give you what is your chance of getting a cancer from your occupational exposure. And then they have eye dose. How much radiation are you getting to your head? Okay. And then the last one is shallow dose, which is your skin dose. I don't know if you've seen, some doctors wear a radiation ring, and this is just giving what's their exposure to their extremities. And I think Venkat at the VA is the only one. I think Stefan has one, but I don't see him wear it too much. I think he's scared of what he would see. So I see his hands in there. Venkat gets his hands in the radiation a lot too, especially when he does epicardiols. So anyway, so these dose reports come to us monthly, or if some badges are only read every quarter. Okay, and there is someone looking at these, but they're only as good as how often you wear your badge and whether you wear it correctly. Okay, so that's my radiation safety officer saying, wear your badge, wear it in the right spot, collar right here. Okay, all right. Now, when you walk into the fluoroscopy suite and you look at the X-ray machine, it's going to give you 4 different measures of how much radiation you're giving. Okay, first one is going to be your exposure rate. When you step on fluoroscopy or cine, somewhere on the machine it's going to tell you what is your dose rate at that current moment. When you step off of it, that number usually will change then to how much your cumulative dose so far, your cumulative air kerma. Those are given in milligray. Okay, the maximum exposure rate during fluoroscopy, just to throw some useless numbers out to you, is about 10 milligray per minute. Okay, to get to 10 milligray per minute, you have to have a pretty large patient or a very steep angle. So the best ways to reduce radiation is to get skinny patients or don't use steep angles. So the circumference of your patient's hard to control, especially at the VA. So I mean, if you go into practice and you can work on little old ladies the most, that's going to reduce your radiation the most. Okay, if you can be selective. Okay, so exposure rate, cumulative air kerma, and then something called dose area product. Dose area product is going to be used to determine basically to see what the cancer risks are to the patient. Because a dose without how much surface area you've given that dose to is kind of useless for determining effective dose. So cumulative air kerma is going to be used to look for your deterministic effects, whether you're going to be causing radiation burns or anything like that. And dose area product is kind of a way to guess what your effective dose is, okay? And of course, it's going to give you your fluoral time, and it's going to ding at you every 5 minutes. Time is about the most useless measure of radiation exposure there is, because dose rate on newer machines where you control exposure, where you can change what the image looks like, plus pulsed fluoral and things like that. The dose rates can change a lot depending on your machine settings. 20 years ago, when there was continuous fluoral, all the machines pretty much worked the same. Time was actually a pretty good surrogate, you know, other than because body habitus would be the only thing.
What about using fluorosave versus cine?
Huge difference. Yeah, so fluoroscopy rates are capped at about 110 milligray per minute. Per minute. Cine is unlimited. It's whatever the machine can put out. So if you look at, even on a large patient, if you're doing 100 milligray per minute, then you step on cine, it's going to be somewhere between 600 to 1,000 milligray per minute. It is a 10, 20-fold, even sometimes 100 times fold increase in the radiation dose that you're giving, exposure rate. Okay, in EP, we'll talk about this later, you can control how much signal to noise ratio you have on the screen, how crappy of an image you have. In EP, I've convinced the doctors to go to really crappy image, because all we need to see is the shadow of the heart and where a catheter is. We're not looking at wires or anything. So our dose rates in EP are a factor of 10 less than what the cath lab uses on their lowest setting, just because we don't need to see that detail that they need to see. So that was a big change that we did at the VA. That took a little painful, but as soon as I showed them their badge readings, they said, "Hey, we like this." So these are the 4 things that you're going to see the machine tell you how much radiation you're giving. Okay. Now with these, we look at what's your entrance skin kerma. So how much radiation entered how much radiation was there at the patient's, at the entrance beam to the patient, okay? So for us in the cath lab, on their back, how much radiation was at the entrance? Cumulative air kerma, what was the total amount of radiation for the procedure? Now, it would be nice to know, as you use different angles, how much radiation was used in each different angle. Because every time you change the angle about 10, 15 degrees, depending on the thickness of the patient and geometry of the table, you'd move to a different skin patch. So if you're looking for radiation burns, if you move 20 degrees, you're going to another entirely different patch of skin. So your chances of skin burn gets lower as you do different parts. Now, if any of those overlap, then you have to take in one strip of skin may have gotten a lot of radiation. Kerma air product or dose area product, useful, but for most if you had to report an incident of high dose, they'd rather see cumulative air kerma than dose area product because they have to do further calculations with dose area product. They have to figure out the size of the field and stuff like that. And then there's this other one called peak skin dose. And that's, like I said, if you use multiple different areas, multiple different air angles, what patch of skin got the most amount of radiation? This is where if you're going to do an FDA or JACO sentinel event for radiation exposure, they have a maximum at 15 gray peak skin dose. It's a sentinel event. So that's where peak skin dose. If you had any one spot of skin get 15 gray of radiation, it's reportable. Now, the VA and other institutions are now getting a little more, I'm going to say, strict. They're actually looking at fluoroscopy radiation safety a little bit more, and we have a new instruction at the VA that if we exceed 5 gray cumulative air kerma, we're supposed to put a note in the record, and we're supposed to do a 1-month follow-up to make sure we question the patient about skin burns, okay? So on a PCI, hopefully you usually come in for a 1-month follow-up, usually see another doctor. That should be a question that's documented somewhere that said, we talked about skin damage, none present, examined, and they should, before they leave the hospital, they should get education about it. We've also added in the consent process, if there's a chance of going over 3 gray of radiation, which is any procedure basically, they need to have in the consent and be verbally told about chance of radiation damage. So the verbal one we're still working on, but it is in the consent. How many of you, if you've done a consent at the VA, if you go all the way down to the bottom, there is a little blurb in the consent about it. Of chance of radiation burn, very small. Yeah, so the chance of getting to 15, so we'll get to that in 1 second. How about that? I got a better slide to talk to about that. Okay, all right. So once again, I like graphics. So exposure rates, entrance skin kerma is what's going to happen at entrance of the patient. Okay, now the weakness of this whole measuring process is the radiation meter is calibrated, and each machine is calibrated a little different because they've changed the spots. When the dose rate meters first came out, they put it right here, right at this is the X-ray tube, because it was really easy. You put it there and you can measure how much radiation is there. Now, you guys heard of the inverse square property. The farther away you get, it cuts it by a quarter. So if you were measuring the radiation here and your patient was here, they're getting much less radiation, okay? Now, most manufacturers have something called the air kerma reference point, which is at the iso center or in the center of the beam. That's where that meter is now calibrated to. All of our machines at the VA currently measure down here. Our new machines, I believe, are going to measure here. So it's going to be interesting to see what the difference of the dose rates I'm seeing once we get up there. Okay, but then the thing is, whatever you're reading, especially when you go to this, if you happen to have a short doctor, you're going to be getting more radiation, okay? Or if you go to a steep angle where your X-ray tube is closer to the patient, your dose rate is higher. So there's a lot of error in these measurements, okay? That's why they've set bars a little lower, like 5 gray. you need to follow up on a patient because you never know what the geometry is. I actually read one article that said if you have a doctor who's under 5'2", you should stand on a pedestal, which I thought, so you can get the patient farther away from the x-ray tube. And it also lowers your radiation too. So if you happen to be a short interventionalist, Matt, yeah, you got to put you on a box.
All right.
Okay. All right. The last thing I want to bring up is how the x-ray enters the patient. Oh, where's my, there it is. When the x-rays enter the patient, one of three things can happen. One, the x-ray can go straight through the patient, and that's what gives you your image. Another thing that happens, the x-ray can come and be completely absorbed, and that's what gives you your black and white, ones that get transmitted and ones that get completely blocked. The third thing that can happen is they can hit the body and they can scatter a little bit. And when they scatter, they can then cause another interaction because they only lose some of their energy, and they can cause multiple interactions. Now, most of the interactions as the x-ray beam goes through the patient happens within the first 3 to 4 centimeters. That's a half value layer of the human body. So half the radiation is attenuated in the first 3-4 centimeters, and then it gets scattered and can have multiple interactions. So when you look at your total cumulative, your entrance skin exposure or your cumulative air kerma, it can actually be up to 40 to 60% higher because of the scatter radiation that happens. It's how much radiation was actually absorbed in that area because of the multiple interactions. So that's called the backscatter factor. So if you ever see cumulative dose of 10 gray, looking into the backscatter factor, if you stayed in the same angle the whole time, you could have up to 15 gray of radiation to that one spot because of that backscatter, okay? So that's something to be considerate of. That's why at the VA, if we get above 10 gray or more, I report it to the RSO for an investigation. Now, I've done it 4 times in the last year. You know, once we say we use multiple angles, you know, nothing there, but at least when JACO comes, we have that, you know, we've reported some, we've investigated. Okay. So that's backscatter factor. Now, when you walk into the fluoroscopy, when you walk into the cath lab, where do you see these numbers? It's going to depend on the machine, okay? This is our Siemens machine, okay? Here's your dose area product, and here's your cumulative air kerma, okay? So that's where it is. When you step on the fluoral switch or cine, this will have a little dash and say milligray per second, or sorry, milligray per minute, okay? So that's where you would see it in the Siemens room. In our GE room, here's your dose rate here, and then on a different screen, you have your cumulative air kerma and your dose area product, okay? And then in our Toshiba room, you have cumulative air kerma and your dose rate on the same, but dose area product is back in the control room. So they're all over the place. So whenever you use a new machine, you should look to see where those numbers are displayed and just know of them and look at them. The other thing that we've added new to the VA is anytime our cumulative air kerma gets above 3 gray or 3,000 milligray, we're supposed to tell the doctor that we've hit that threshold. And then every 1,000 after that, we're supposed to also say something to the doctor. Newer machines are coming out with automatic alarms for those. You can set those levels. So you have the 5-minute timer going, plus you have a cumulative air kerma timer going. So that's going to be fun when we get to new machines. So, and the other nice thing is then when you're looking for peak skin dose, all right, now I want to say this, I think I have it later. They've also taken the body and gone into 9 different angles, aurial, cranial, frontal, so kind of around the world, divided the body up, and it will track how much radiation you had in each angle. So I think it's every 20 degrees. If you go 20 degrees caudal, it's gone to your caudal. 20, if you go to a spider, it's going to look at just radiation in that angle. So it's going to do a better job of looking at what your peak skin dose is.
Do they have that then calculated for operator exposure? Because you'd think, knowing that like LAO training, when you're straddling the radiation tube,
Yep.
the X-ray tube, that you would kind of get a better understanding based upon your patient exposure.
No, they don't have it, but once again, the VA, Some hospitals have this, we're getting it, it's called dose aware. It's real-time radiation monitoring. You have a display. If you have a 52-inch display, it can actually be one of your screens. It'll show you, as soon as you step on fluoro, you're going to see a little line go up and tell you how much radiation you're getting right now. So it's going to be an interesting tool to have, to see. So, but no, the general rule, which I'll go over later, if you're 2 feet away, you get about 1/100th of what the patient is getting. 3 feet away, you get about 1,000th of what the patient's getting. Okay. Other than that, you got to look at your monthly badge reports. Okay. So objectives of radiation protection. This is really for the patient. Once again, to prevent the deterministic effects. So what are the deterministic effects we're trying to avoid? Okay. So first, deterministic effects tend to have a threshold below which they won't happen. And then as you go past that threshold, your chance and severity of those effects get greater. Okay. So what's the threshold? This is from the FDA. So the first chance of getting a little skin erythema is around 2 gray. Okay, this would be someone who is very radiosensitive, usually because of drugs they're on or some other genetic factor, which there's a big long list. I don't understand half of them, so I don't know what the drugs are and I don't know what these genetic defects are. But so around 2 gray peak skin dose is where you can start seeing some people get skin reddening. And then as your dose goes up, you can get all the way to really bad ulcers, and you can get stuff like this. Okay, so two coronary angioplasties. Okay, you know, nice skin reddening, nice deep ulcer. EP procedure gone bad here. This is an EP procedure, and then this is a stroke protocol. So this is just hair loss from doing a cerebral stenting. Okay, so they can get this bad. Okay, I've been fortunate I haven't seen any of this. And for those of you who don't do fluoroscopy, this is what can happen in CT. Okay, these were from stroke scans on a CT. So you can see nice coned in hair loss. So there's these pictures, I think these pictures came from this study in California. I can't remember which university. They had their scanner set in a demo mode, and when they first got it, the technician who set it there didn't take it out of that, and they were scanning patients in the demo mode, which is a super large amount of radiation. And they didn't know about it because they weren't tracking their doses or looking at them. And then patients started showing up a few months later with hair loss. And that's how they found out about it. So always know, if you do go into CT, know what an appropriate dose level is for your test, and always at least glance at it. You know, make sure the tech isn't doing something wrong, things like that. Okay. So those are the deterministic effects we're worried about for the patient, is skin damage and hair loss. And like I said, 2 gray, I very rare you would see something like that. 3 to 7 gray, our average angioplasty at the VA is 3 to 7 gray. Okay, so a % chance, very small. You know, it can happen, but only if it becomes a very complex procedure. The only time we're really going above 7 to 10 gray right now is in our oldest room, because we can't control the pulse rate or the dose rate in that room. I mean, it's a 15-year-old lab, first generation digital detector, very unadjustable. Okay, so that's room 3. Yep. So that room, I hate bringing. We do our absolute best to not bring anything that we think could be a complex plasty into that room, because that's the room that's bit us the most. That's, of the 4 that I've reported in the last year, all come from room 3. So if you go to the VA and need a complex plasty, don't go into room 3. That's the general rule. And like I said, it was going to be very interesting when we get our new rooms to see if those dose rates go down as much as they say. They say we should get a 30% reduction in what we have now because of the new technology. So it's going to be interesting to see. All right. So the second objection of radiation protection is to limit the risk of stochastic effects, okay, to a level of acceptable risk. Okay, that's the key there. So our stochastic effects, our stochastic effects are considered, their dose response curve is considered linear non-threshold. Okay, so there's no radiation specific cancer. You can't get a cancer and say that was caused by radiation, even if you've had x-ray tests in the past. And everyone is exposed to radiation just living on the earth. Okay, so what the prevailing hypothesis is anything above normal background radiation is going to carry with it some risk. Okay, but what level is that risk? So what's the slope of this curve? So here you go, 5% per sievert for general population, 4% per sievert, 18 to 60, and 15% per sievert less than 16 years of age, okay, is the slope of that line. So 1 sievert is equal to 100 rem, okay? So by comparison, what are you allowed to get occupationally in a year is 5 rem, okay? So that's where we'll go over that in a second. I got some fun percentages to play with. So this is from the low-level radiation, BEER 7 is Biological Effects of Ionizing Radiation Committee. So at 10 rem, okay, sorry, number of cases of cancer, solid cancers with no exposure is 45,000 per 100,000 people, okay? Now, if you got 10 rem of radiation, you would see an excess of maybe 800 cases of cancer, okay? And then excess deaths from that, 410. So they assume a 50% cure rate in their cancers, okay? So graphically, if you look at it, if this is 100,000 people, all the colored dots are the people who would get a cancer. The red ones are the ones who would die from a cancer. And if you got 10 rem of radiation, full body, so it's effective dose, that star would be your excess cancers in 100,000 people. So the chances are very small, okay? So then we have to decide what is our level, what is, as a society, an acceptable risk from radiation, looking at those percentages. And before we do this, I just want to say a couple things about the linear non-threshold. It is controversial on whether or not its validity, okay? So the Health Physics Society, they recommend against quantitative estimation of health risks below doses of 5 rem or lifetime doses of 10 rem, okay? Because your normal background radiation, everyone in the US, by age 17 will get 5 rem by the age 17 and 25 rem by the 80 years. So an additional 10 rem from an occupational exposure, when you've already, you're going to get that from normal background. Is it, once again, how accurate are those statistics? Okay, so any risk estimation should be strictly qualitative, okay, because the risks or health benefits are either too small to be absorbed or non-existent. Me personally, I'm not a big believer in the linear non-threshold. I believe there is a threshold below which, or that the estimated risks are so small compared to other risks we take in life, they're just not that important. Okay, so principles of radiation protection for the patient. First, justification. There should be good justification for the reason you're prescribing radiation to a patient, okay? Are you going to get some benefit from this, okay? Optimization. You should use the lowest dose of radiation possible, okay? And then limitation. There is no, I've said this once and I've got arguments with this. There is no limit to the amount of radiation you can give a patient, as long as you believe there is a benefit to it, okay? At some point, if you're in a complex plasty and you're at 10 gray, is it worth the risk of getting a skin burn to continue going? Okay. Now, if you just took a break and brought it back a month later, those doses are considered additive. You'd have to take a couple years off before they really consider it not additive. Okay. So those are things you have to think about. Can you switch to a different angle? Things like that. What can you do to get radiation off that one? So there is no risks. I mean, there is no limit to how much radiation you give the patient. You just need to make sure there is justifiable benefit to it. Okay? So, I'm going to skip this one. So, what is the effective dose from an angiographic or EP procedure? So, this was a study that did all kinds. They looked at, these are all EP procedures. So, when you break it down, they look at what's your average dose area product, average fluoral time, and then what's the average effective dose, okay, of radiation. And then I took that and I compared it to what we do at the VA. So the study here, so our PCIs, if you go by dose area product to effective dose, okay, so EP procedures 11.7, PCI 70.5 millirem, okay. Now the biggest difference in this, once again, is our fluoral exposure rate is much lower because we accept a crappy image, okay, and we don't cine. Remember, cine is a ton more radiation. We very rarely cine, you know, so you can see what the average effective doses are. And those are kind of in line with published things, okay, coronary angiogram, 16 millisieverts. So we're in the ballpark, maybe a little bit higher. I blame that on fellows. Sorry. I got to take my shots when I can. Okay. So when you're explaining this to a patient and you ask, what are my risks of cancer from this procedure? What should you say? This is what most, the people who make up the rules say. So you look at your millisievert range, and then you have what's your risk descriptor, and what is the benefits that you need to justify that procedure, okay? So angiograms are going to be somewhere in here, 10 to 100 millisieverts, okay? So it's a low-risk procedure, and you should have substantial benefits from it to justify it, okay? Now, once again, the cancer rates as you get older, I mean, I always feel mean when I say this. If you're cathing a 60-year-old person, what are their chances of making it in another 20 years, which is the latency period of a cancer? Pretty low, right? Now, if you're doing pediatric stuff, it's a completely different equation, okay? So you have to look at the patient you're working on, okay? Just once again, for risk range for low, so this is our interventional radiology, cardiology. The risk range is 1 in 1,000 to 1 in 10,000 chance of a lifetime cancer from an angiogram or angioplasty, okay? That's what you can quote the patient that, or just say it's a very low risk. Okay, so enough about patients. Let's talk about us. Okay, so stochastic risk to staff. The first thing you should know is how much radiation do you get a year? Anyone know? Because I'm going to say no because no one's seen a radiation badge report, which is sad. Which is the common answer. No one sees these. I don't know why we keep them so secret. I'd like to post them on the wall, but we can't do it. Okay, so once again, operating for staff, justification. The activity should benefit society in somehow. So by doing CAS, are we benefiting society? Depends on who you ask. Awesome question. Depends on who you ask. Yep. Okay. When you do it, are you using the lowest amount of radiation possible, and are you taking as many precautions as you can that are reasonable? Okay. And limitations. Once again, we have to set a limit somehow where we say the risks you're taking because of your occupational exposure far exceed what they should. Okay. So this is the next question. First, you should know how much radiation you get, and then the next question you have to ask yourself, what is your level of acceptable risk that your job is going to kill you? Okay? So, okay, who says 1 in 100? That's marriage, yeah. No, okay. Okay. 1 in 100,000 that your job is going to kill you. Okay? You know, people usually like these two. Okay, so keep that number in mind. You don't have to share it with me. Keep your number in mind. What's your level of acceptable risk? Okay, so at the VA, we have 127 employees that have badges, okay? And if you look at how much radiation to get, our max radiation was 1,600 millirem, minimum was 11, average 191, and median, so half the people got less than 50 millirem, okay? This little chunk here is our GI doctors and cardiologists and interventional radiologists. Okay, that's these people right here. Okay, so 14% of the people get above 1 millirem. Okay, 500 to 1,500 millirem a year. Okay, so one thing to know about dose limits, they are not dose allotments. Okay, that doesn't mean you're allowed to get it. You should try to keep it as low as possible. And once again, you have to determine what is your level of acceptable risk. Okay, so now the question. So there is a dose limit out there. I'm not going to tell you what it is. What do you think your chance of developing a fatal cancer is at the dose limit that is set by the United States government? 1 in 1,000? Okay, here you go. So we're allowed 5 rem a year, okay? Or if you look at it, 1 rem for every year of work, if you look at what your lifetime exposure is considered acceptable, okay? So if you get a lifetime or a one-time dose of 5 rem, it's considered a 1 in 500 chance of dying of a cancer from that 1 dose, okay? Or if you look at 1 rem a year, so 3 in 100 at age 70 if you got 1 rem a year from occupational, okay? So if you got 60 years of radiation, okay, you got a 3 in 100 chance of dying from a cancer because of that. Okay, so to break it down kind of per month, okay, so if you get 41 millirem a month, which is about what I get, I'm looking at a 0.4% increase in my chance of cancer, of dying of a cancer over my 20% already just living in the United States. So is that acceptable risk to me? Okay. Now, once again, that's measured outside the badge. I'm wearing lead, so my total effective dose is going to be cut down by at least 90% of that. So that's what's just read on the outside of my badge.
So that fatal cancer is if you didn't wear lead?
Yeah, if you didn't wear lead. Yep. So right down here, you should, if you're wearing lead properly, you should be your risk should be at least 6 times less. You're really a lot lower. Yeah, because you're covering 80% of your body with properly fitted lead and a thyroid collar. You're covering 80% of your bone marrow and body, okay? And it attenuates anywhere from 80 to 90% of the radiation that hits it, okay? So this speaks to, do you want to wear shin pads? Do you want to put an arm? Some people are getting their left shoulder covered, and Mac, if you get there, is getting complete sleeves on his left arm. Tattoos. Yeah. Yeah. So, okay. So if you look at it to other occupational things, these are for 40 years and this is 20 years. So a little bit of different. Doctors don't work as long. Oh, come on. My best joke I got. Okay. So if you look at, so I mean, if you're getting somewhere in there, you can be as dangerous as working in a mine. Okay. Depending on how much radiation you're getting. Okay. So just me working in the government, I have a 0.4% chance of dying there, and I have a 0.4% chance of dying at work. So I'm not sure how to take that. Or if you look at it this way, your risk is somewhere between drowning and accidental firearm discharge. Okay? Or I bike. Yeah. You saw bicycling? Yeah, and I bike. And this one is interesting. How many people have tested their house for radon? Okay, I just did mine I just got a new house, so I did it. And if you look at 2 in 1,000 people, so that's the same risk, occupational risk as the 5 rem, okay? And this is what they say, it's hard to reduce it to less than that level, even with a good radon. So if you look at it, even just living in a house in Minnesota, your chance of dying of lung cancer is the same as the occupational dose if you get 5 rem radiation from occupational dose. So that's what I mean. You have to put it in context. If you say 1 in 500 chance of dying, it sounds bad. But if you look at other things that we do that can also cause us to die, it's actually relatively small. Okay. I'm going to skip some of this because I want to get to radiation protection. Okay, so if you look at per procedure, this is from that same study. Average effective, your dose area product, average fluoral time, and DAP per minute. This is actually a pretty low DAP per minute, okay? This would be almost what we do in the EP lab, so on the cath lab side, it's gonna be a little bit higher. But then you look at what is the risk per procedure for each one, a primary operator, you know. So like I said, the risks are small, but over a 20, 30-year career with 5, 6 procedures a day, you know, it definitely adds up. Okay, cath lab radiation levels, and I thought this was very interesting. So we have a radiation area monitor right on our monitors in our cath lab 1, which is our highest used lab. And if you look at the amount of radiation that badge has gotten from 2010 to 2015, it has dropped every year. Numbers of procedures, I didn't update the slide. I had that, I was going to add that to it. Number of procedures have gone down by about a quarter from 2010. So about 75%, 25% less procedures than what we've done in 2010. Between 2012 and 2015, the procedures didn't change that much. You know, we went from like 1,000 down to 950, 920. One of the things I attribute this drop to, especially between 14 and 15, is we've defaulted all our machines to 7.5 pulses per minute versus 15 pulses per minute, which it usually reduces your dose by 30 to 40%, just by doing that one simple change. I was trying to implement that for years and everyone was arguing with me. So I decided to do a study and I just started changing it down to 7.5 without telling anyone. No one ever noticed. No one ever noticed. Except for when a certain tech came in a couple of times and went, oh, why are we at 7.5? And then people, what, we're at 7.5? And they got all upset. Okay, but when I did it without telling them in my blind study, no one ever noticed. And when it came up and said, well, Chris changed it, I said, oh, did I? Oops. So I did a blind study, no one really noticed, going down to 7.5. Okay. Once again, my radiation, so my lifetime radiation so far, you know, 2,000 millirem, 2.5 millirem. Sorry, 2.5 rem. I'm not too worried. Okay. This was fun. I went back, dug through our radiation records we have. Our doctor lifetime doses. So, yep, Dr. Weir. I was told I could share his name. That's Dr. Weir. He was our chief of cardiology. Yeah. So he was our chief of cardiology before Dr. McFalls. So yeah, some of you probably haven't met him. So. Yeah, he's pulmonary hypertension guy. So interventional cardiologists, we average about 1,400 millirem a year. The last 3 years, we've averaged 1.1, okay? EP doctors, and then our diagnostic-only doctors, how much radiation they've gotten, okay? I'm just gonna say, since we have extensive control on how much radiation exposure we get on our job, we should do our best to minimize it, okay? So, how do you lower doses? So, anything you do to lower the dose to the patient, you lower the dose to yourself. So, what are things we can do? One, stay off the fluoro pedal. If you're not looking at the screen, take your foot off the pedal. Okay, it does happen. I do yell at people for that. Okay, use pulse fluoro. Use the lowest pulse rate that you can and still do your job. Okay, Stefan does it every once in a while. I'm reading more and more about EP labs doing it, going down to 3 frames per minute instead of 7.5 even. It's a very jerky picture, but once again, every time you cut your pulses in half, you reduce your dose by a good 30, 40%. Okay? And then a bunch of stuff. One, default to the lowest settings. That was a big change we also did. Our machines come in at the lowest setting, and we have to up the radiation if we don't get an acceptable picture. It was the other way. We have the highest setting, and then I'd have to beg the doctors to change. So instead, we had Siemens come in. It was actually a service call, and they had to change it so it default to the lowest settings, and then they asked to go up. Okay. Avoid steep angles. Use store fluoro instead of Cine is a big one. You know, all those balloon inflations, instead of Cine, hit store fluoro. We're doing a lot better job of that. Okay. And of course, actively monitor dose during the thing.
How does that affect?
Okay, so as you increase your magnification, you're irradiating a smaller patch of skim. So you have the same amount of radiation. Actually, usually when you mag down, the machine actually gives a little more radiation. So you're concentrating the same amount or a little bit more radiation to a smaller area. So you're increasing the dose rate to that small area. Does that make sense? Yeah, so that's where you can actually get almost a square increase in your dose rate to the local tissue as you meg. So use the lowest magnification. Yep. Use the biggest field of view and cone down if you can, because that will also do it. So use a big field of view and just cone down to the area that you need to see, as long as it's clinically, because if you miss something, then it's radiation wasted anyways. So all these suggestions are, you have to be able to make your diagnosis and do your job, because if you can't do those and you've given radiation, you've wasted it for no benefit, okay? No. Steeper angle, in the average patient, it should be thinner this way than this way. It's not always true. Some patients are as thick this way as they are this way. So that's what it is. As you get steeper angles, you're going through more matter. And and the X-ray machine, to get the same image, is going to increase, because they all have automatic gain control. They all automatically adjust the X-ray tube, so they give you the image that you've programmed it to give you. So as you go to steeper angles, you're going through more tissue, it's going to up the radiation. And the X-ray tube is going to get closer to the patient as you do a steeper angle, so they're going to get more entrance skin exposure. And we'll talk about angulation and staph exposure here in a second. Okay, so that's the other thing. When you walk into the lab and you start doing fluoroscopy, you should know on the controls how to adjust your dose rates, okay? On our Siemens, it's literally easy. It's just a touch panel right alongside. Okay, you just touch each one of these buttons. We got our lowest, you see, it used to be defaulted here. Now it's defaulted to our fluoro minus, okay? And then fluoro plus, so it's literally a button push. And if you do want to go up to 15 frames, it's 2 button pushes, okay? So it's very easy, and there's no reason. And the store fluoro button is your friend, okay? Always know where your store fluoro is, which room 3, once again, at the VA doesn't have store fluoro, so it's not even an option for us. Okay. This is your dose reduction as you change your pulse rates, okay? So you can see there's a big drop every time you half your, which as you would expect. Okay, and now this is the difference between our crappy fluoral, our good fluoral, and our best fluoral, okay? So this is what we see when this is an actual EP case, of course. There's an EP catheter right there out the coronary sinus. So this is the image that we usually use most of the procedure. Now, when we're doing something like we're doing a transeptal, doing an epicardial access, something where we need to see better, then we'll step up to this next one. You can see what the jump is in our radiation, from 7 milligray per minute up to 31, okay? And then our best fluoral, this is what the cath lab was using. This is at 15 frames. This is what the cath lab was using as their default for years. I've got them to switch down to this one, the 7.5 frames. So you can see, but like I said, it half the dose. So very important to look at. And what I find really cool now is I actually have doctors, I've worked enough with the doctors that us as techs know when we need to change the fluoral for them. So they don't even ask anymore. They just expect it to happen. But if for some reason now, if I forget to change it back, I'll actually have the doctors looking at the picture and saying, this is too much radiation. They can tell now visually, and they're asking for dose reductions. It's taken 10 years, but it's happening. Okay, so reducing dose to staph. What is the triad of protection for, okay, time, distance, shielding. Once again, stay off the fluoral pedal, reduce your time. Okay, distance, stand as far away from the patient as possible. That's why I like being a tech or second operator. Doctors make great shields, okay? So do fellows. So it's great when there's a doctor, a fellow, and me. I'm golden. Okay, so if we look at what dose rates, now notice this is with absolutely no shielding, okay? And of course, as you get a fatter patient, okay, your dose rates are going to go up, and the dose to the operator is going to go up, okay? So how do we protect ourselves from this radiation? Oh, angles. And as you change your angles, okay, well, I'm going to go back. Now look at the most intensity is below the patient on the X-ray tube side, 90 degrees to the patient is where the most radiation happens, okay? And then it goes down from there, okay? So remember that. X-ray beam comes this way, 90 degrees is about the highest amount of radiation. So as you move your fluoroscopy, so you're standing on the right side of the patient, when you go LAO, you get more radiation to your head, okay? As you go RAO, you get less radiation. So you always want to be on the image receptor side. X-ray tube side is not your friend, okay? So if you look at dose rates and different projections, so LAO, the LAOs are by far your highest amount of radiation, and 80% of your dose comes from the left projections. Okay, your LAO cranial, LAO caudal. Okay, now this is going back just one step. This is what the new machines are doing. They're dividing the patient into each one of these different locations and monitoring how much dose is in each one of those locations. And they're roughly separated by 20 degrees, or this one is saying 10 degrees. Okay, so avoid LAOs, and if you have to do LAO, use your shielding. Okay. So what's the best way to position your shielding? Okay, should make sure you have an undercouch. Okay, it's amazing how many labs I've gone into that don't have undercouch radiation protection. ORs, I don't know why it's not standard in ORs. None of our OR tables that use fluoroscopy have undercouch shielding, and it drives me nuts. Okay, overhead shield, that's also your best friend. Okay, that's going to minimize how much radiation gets to your head. Okay. They recommend having this little additional shield coming down. If you go through the EP rotation at the VA, you'll notice we have a piece of lead that comes in perpendicular to the table. That's my simulation of this, okay? So, and why I do that is I don't know why in our EP lab, we use the LAO about 2 times as much as we use the RAO. So we're using the worst possible angle for staff radiation. So that's why this is a very important shield to me. That's why I'll always put it in, okay? And they also recommend using the rad pads. If you guys seen rad pads, know what rad pads are, definitely will reduce your dose. Okay, so rule of thumb, without a lead drape, you're at about 1 foot away, you're about 100th, 3 feet away, you're about 1,000th. If you use a lead drape shield, you're going to cut it down by 75 to 88%, okay? Depending on which article you read, I've seen up to 95%. It all depends on how you're running your tube. No, and what we've decided, I don't have this article, there was a cost-benefit analysis of how much should you spend to reduce radiation by how much, okay? In a typical cath, if it's less than, the golden cath rule is, the VAs, we want to get our fluoral time under 2 minutes. So if you're using standard radiation protection, the dose to the patient, we've decided, I don't know who we are even, somehow I'm grouping myself in that, we don't need to use a rad pad for diagnostics. If a doctor asks for it, I think it's more than reasonable. I am more than willing to give it. They're $50. So $50 for a 2-minute procedure, they're not recyclable. They're one-time use. So that's where cost-benefit analysis is. Once again, if someone wants it, I will request it. I'm more than willing to give it to them. Okay. Because once again, what's reasonable depends on the person's perspective. So I'm not going to argue what's reasonable. Okay. Upper lead, this was an interesting article, Optimizing Radiation Protection for the Operator. I see a lot of people position the lead right at the image receptor or right next to the C-arm. This article says it should be right next to your hands. Okay. It's a little more inconvenient, but it's going to reduce it by the amount of radiation you get to your head by about 4 times. So once you get your femoral access and you're working, get that lead as close to your hands and as tight to the patient as possible. If you're buying a new lead shield, you know, we have one of these, but they either make a solid one or some with a little lead drapes that go down. Those are better because you can get a tighter seal because they're flexible and they're contour to the patient a little bit better. And in our new labs, we're going with all those on our new labs. Okay, so this is interesting. So green is without shielding, undercouch shielding. You go down to here with your couch and your above shield, and then this is your personal protection. What do you think's here? That's the head, and he's wearing leaded glasses. Okay, so to prevent cataracts, which is one of the late effects that can happen, wear lead glasses. But this also brings up, look how much radiation the cranium's getting. Okay, so what is the risks? Okay, and so there's a new rad pad hat. Okay, no-brainers. Okay, this is the first ones to come out. It's a lead hat that you put around here. Once again, more than reasonable. We have them. If you want to wear them, go for it. Okay. The thing I found was I looked at what studies they quote. Radiation is the only proven cause of brain tumors, and they all quote the same article. So I looked them up, and there are secondary brain tumors in children treated with radiation for lymphoplastic leukemia. Okay, they got 24 gray dose. Okay, so huge doses of cranial dose or 40 gray dose to the head at 3 years of age, and they got secondary cancers. I'm almost done. Yep. So, but this was one that came out recently where they found 31 interventional cardiologists, electrophysiologists, and interventional radiologists who had brain tumors. Okay. And they looked at 17 cases, 55% of them were glioblastomas, and then these guys. The interesting thing was 85% of them were left-sided. Okay, this number I'm not overly excited about because I did a little research. Lifetime risk of developing brain or nervous system cancer is 0.7%. Okay, in 2009 we had 7,300 interventional cardiologists and EP. So you'd actually expect a baseline of 50 cases of brain or nervous system cancers. So a cohort of 31 doesn't excite me too much. And glioblastomas are 52% of all primary brain tumors anyways. The most interesting thing is the 85% of them were left-sided. The rate doesn't really seem all that impressive, just with a little bit of research. But now, this is the last one. You asked about wearing lead protect a leg. Okay, we had one guy from Australia come in here, and he had lead over his shin. So it was the first time I'd seen it. This was about 8 years ago. And, you know, so we had some requests to get it. And then this was a little paper that was written, the older cardiologists are losing their hair on their left leg. Okay? So my great story is Santiago came to me. I'm scrubbed in plasty with Santiago, and he looks to me and goes, I wish I could do his accent. I can't. I'm going to try. I was in the shower last night, and I was thinking about you. That's how he started the conversation. And I said, okay. He goes, my left leg, I'm losing all my hair. So once again, left side, if they're out there, if you want to wear shin guards, you have undercouch lead, but it still has this much. You know, especially if you're tall, it goes up with the table. They do make foot pedals with lead protection too, if you want to go really nuts. So once again, it's all what's reasonable to you. So there they are, lead aprons. If you want to go really crazy, zero gravity or cabins. Okay. Yeah, we trialed this for a little while. $50,000 well spent right here. Yep, so this was one I found, 1984 study. This is my last, I just want to look at so they measured how much radiation the primary operators got in 8 angioplasties. Okay, so in just 8 procedures, 140 millirads, 130 millirads. So their suggestion was limit the number of angioplasty procedures to 5 cases per week. Okay, and perform no other fluoroscopy procedures. That was their recommendation in '84. But look at their radiation protection. They taped lead to the X-ray machine. Okay, And the lateral plane had none. And there's no undercouch lead that I can see, no above shield, so we've gotten better. Okay. That's it. Yeah. Yeah, unless you want to do my other 50, 60 slides that I rejected.
No, that was great. That was great, and I think it hits all the high points of the background.
Yeah.
I think, your lecture last year, I didn't quite understand. You know. Just watching, maybe a little bit, yeah.
500. Four or 5 months.
So your first year of fellowship is probably your highest of your life.
Yeah.
Because you're the slowest, you're front all the time, so I would say that would be the acceptable risk for 1 year. I wouldn't want to do that.
Yeah.
For a lifetime.
For a lifetime, yeah.
And that's outside of the.
That's outside the lab, yeah.
So then you start looking at